The purpose of this program is to give you an overview about ALS so that you can understand more about the disease as well as some of the resources available to you. This video is for educational use only. It is not intended to replace consultation with your healthcare provider.
I have been working with ALS for a long time. It's really a passion for me, and I see many people here who I know and some new faces as well. I'm just delighted to be here and give this presentation, and absolutely delighted that the ALS Association has decided to videotape this so it can be available to people around the country. It's especially helpful for those people who are newly diagnosed and their families. I like to think that you get the straight scoop from me, which is a little different from what you get in the literature, and that it's an excellent program to share with your friends and family when they say, "Oh, I'm so sorry you have ALS, tell me about it." And instead of having to explain things over and over again, just show them this presentation and tell them, come back and talk to me after you've seen this. So, we're going to talk about hope, because I've been, as has been said, I've been doing this for about 30 years. Equipment has changed terrifically. What we know about ALS has changed dramatically, even as of 5 years, 10 years ago. People are living longer today and having a better quality of life today. And I'm going to show you some of the reasons why, things that we've learned through research and through better care of people. So I get tired of people always talking about hope for tomorrow, hope for the future, hope for tomorrow. Geez, oh Pete, we've got hope today because we're building on what's happened over the last 20, 30, 40 years. We're going to talk about the background of ALS, what it is and what it isn't. I think it's as important to know what it's not as it is to know what it is. Familial ALS, which affects about 10% of our ALS patients. Cognitive and behavioral changes. This is something that's really come into the fore in the last 10 years or so, a recognition that some people with ALS also have an overlap syndrome of either thinking and memory problems or behavior problems or both. And we'll spend a little section on that so you have a better understanding of what that is. Treatment that works. Okay, this is the funnest part for me, to talk about treatment that works, what we've known through research that really, really works to lengthen life and improve quality of life. And then we'll talk about clinical research, some of the stuff that's going on right now, and some of the things that we're going to see in the future. A little bit about background. First, let's talk about types of nerves. So nerves are grouped in terms of families, so to speak, or trade unions. You've got your carpenters and you've got your plumbers, and if they're in the union, they don't do each other's work. Well, you've got sensory, autonomic, and motor nerves, and they're very distinct and different from one another. They have very different jobs to do, and they don't do the job that some other nerve group does. We're going to concern ourselves today with the motor nerves, but first let me just say something about the sensory nerves. Sensory nerves take information from the environment, bring it up to the brain. They keep us safe. Something is hot, don't touch that stove, it's too hot. Cold, sharp, dull, numb, tingly, those kinds of things. Our eyes are also, the five senses. Our eyes have sensory nerves, and they look at color and light. Our ears, sensory again. Sound, they interpret sound. Then the autonomic nerves. The autonomic nerves are those that take care of automatic functions. So the automatic functions are those such as heart rate and sweat and blood pressure, temperature in men, erections, Men are always pleased to know that that's not part of the motor system, so not affected in motor neuron disease. And then the motor system, and this is really what we're going to talk about today, and that's communication from the brain to the muscles, telling the voluntary muscles that you want those muscles to do something. Now, what are the voluntary muscles? Those are the muscles that you control, and you control kind of looking top to bottom. You can furrow your brow, you have facial expression, you can smile, you can frown. Some people can wiggle their ears. I can't, but some people can. Muscles in the neck to hold up your heavy head. Head is very heavy, big muscles in the neck. Arms and legs, that's pretty self-explanatory. And then muscles of the trunk to make us look pretty if we can suck our stomachs in, but also to hold us erect, help with bowel movements. And when people lose their core muscles, they have trouble with those activities. And then respiratory muscles. Now, the respiratory muscles are a mix of voluntary and involuntary, because if it were all voluntary, when you slept, you wouldn't breathe. We can't have that. So there is a central meaning in the brain mechanism to keep us breathing at night while we're sleeping, but we can hold our breath, we can pant. It's very much voluntary. What's not affected? So you can think of two big muscle groups, very, very important, but they're not affected because they have different kind of muscle. It's the heart muscle and the gut muscle. So the muscles that we think about in arms and legs and what I've just talked about, the voluntary muscles, those are striated muscles. And the heart and the gut are not striated muscles. They're not affected. So your heart does not have difficulties in ALS. If we talk about motor neuron disease as a group of diseases, it's where the motor nerves, just those nerves that are taking messages from your brain out to muscles and make movement happen, your motor nerves, they get damaged, they get hit, they get damaged, something happens. They degenerate and then they die off, one by one. To an average size muscle, you've got about 300 of these motor nerves on average. And then at the nerve starts as a cell body in the nerve that takes in the information, processes that information, makes sense of it, sends it down what I call the extension cord. It's really the axon of the nerve, and then spreads it out in branches at the end, terminal branches. And these branches then go to a single nerve fiber. A single branch from a motor nerve goes to a single muscle fiber, and they match one-on-one. So each of those 300 motor nerves going to an average muscle can branch about 1,000 times. So on average, you've got about 300,000 connections to an average size nerve. So one by one, these connections are being lost, usually in a pretty steady fashion. So in adults, we've got three kind of categories of motor neuron disease. We've got ALS, we've got PLS, or primary lateral sclerosis, and I'll make sense of these names in just a minute, and progressive muscular atrophy. In children, the motor neuron disease that is most prevalent in children is spinal muscular atrophy. And there's some research technology that has come out that's been tested first on SMA babies, that's now being tested in certain kinds of ALS, familial kinds of ALS. And we'll talk about that later, but a brand new drug was just approved for spinal muscular atrophy in adults, and it was such a powerful drug in terms of the results that the FDA said it is unethical to continue to have a placebo-based study when the results from this study during an interim analysis were so outstanding. So they approved the drug early, stopped the study, and spinal muscular atrophy is now being treated with this miracle drug for them, for these little babies and children. Same technology is going to be used in some genetic forms of ALS. Spinal muscular atrophy is also a genetic disease. Neurodegenerative disorders is one in which a particular kind of nerve gets hit, is damaged, degenerates, and dies off. So we've talked about how ALS is a neurodegenerative disorder. But so is Parkinson's, Alzheimer's, and in these disorders, discovery in one disease has the potential to lead to the discovery in another of these neurodegenerative disorders. So sometimes you'll read in the paper a new drug for Parkinson's or a new discovery about Alzheimer's, and then they say this may have implications for blah 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 and ALS. So when you hear that in the news, it's great to be excited, but it's a long way from being studied in ALS. But nonetheless, these things do kind of come together. Okay, so let's talk about ALS. So how does ALS get diagnosed? A lot of people say that ALS diagnosis is a diagnosis of exclusion. You exclude everything else, it takes a really long time, and then you've got ALS. Well, the way that I was brought up in neuromuscular disease and my mentors in ALS, it's not a diagnosis of exclusion. If you know what you're doing and the disease is moving along at an average kind of pace, you should be able to discern exactly what's going on, because ALS has some very unique features. So first of all, they look at history. So the physician will chat with you about where did things start, when did they start, what happened next, what signs and symptoms are there, what signs and symptoms are not there. So it starts with weakness on one side or the other. It can be distal, away from the body, proximal, close to the body. Usually starts on one side or the other. Very rare for it to start together. So in neuromuscular diseases, usually they are length dependent. That is, they start in the toes and move up. When they get to about the knees, that the nerves in the arms will equal about the length of the nerves that go from the lumbar spine down to about the knees, so then the hands will start to be affected. And most of these disorders are mixed sensory and motor. So we're talking purely about a motor neuron disease. Sensory system is not involved. And then, again, it starts either proximal, distal, and has progression over time. It starts in one area. We call those spinal regions. So you've got the cervical spine, which goes to the arms. You've got the lumbar spine. Those nerves go down to the legs. It spreads most often from one side to the other side, but it can spread from, say, it starts on the right arm, it can go down to the right leg. On exam, the doctor will notice that your reflexes are brisk. So if the doctor holds your knee up and presses, it jumps a little bit more in a pronounced way than it would normally be. So the doctor knows that that's a brisk reflex. So there would be brisk reflexes throughout. There is weakness and atrophy. So not all weakness comes with the withering of the muscles getting smaller. So there's both weakness and atrophy in an asymmetric pattern. Sensory nerves are normal, other nerves are normal. And then the big test that tells us what's going on with ALS is the EMG, electromyography. And the doctor will put a needle in and see how the nerve is talking to the muscle. And what they see is a pattern where muscle has lost its nerve ending. We talked about that just a minute ago. There are some muscles that have lost their nerve. And then so that's denervation. And then there's reinnervation, where the neighboring nerve will help out by becoming a super nerve and sprouting more branches. And so it's a clear pattern that's seen on EMG. Denervation and reinnervation. Even before there's weakness, the doctor can see on the inside what's going on. And of course, MRIs are done because impingements on the spinal cord, for whatever reason, can mimic ALS, but they often have sensory signs along with them. Let's talk about how movement happens. This is always my favorite part of the talk, because then I get to drink my water, and I always get a dry mouth when I'm presenting. So what just happened there? Okay, I wanted to have a drink of water, right? So I thunk a thought, and so that's in my brain, number one here. I think a thought, and then that thought gets picked up by the upper motor nerves. So you've got two sets of motor nerves. Upper motor nerves that start in the brain, in the motor cortex of the brain, and their extension cords or axons go down the spinal cord. Now, they don't go down the spinal cord willy-nilly. They go down the spinal cord like telephone wires that are bundled into telephone cables on either side of the spinal cord, on the side of the spinal cord, in the lateral area of the spinal cord. So I thought a thought, upper motor neurons, just the ones that were needed, picked up that thought and said, okay, we'll put some action here. Then picked up in the spinal cord, in the anterior horn, and you might sometimes hear someone say anterior horn disease. That's kind of a euphemism for motor neuron disease. So the upper motor nerves, when they're ready to talk to the lower motor nerve, that nerve will come into the anterior horn area, and they don't plug in like extension cords. They get really, really close. Chemical reaction happens. The lower motor nerve is activated, pick up the message, and that message goes out to the muscle, and over here we see robust muscle, good nerves. On the other side, what we're seeing, nerves that are lost, upper motor neurons and lower motor neurons, and a muscle that has withered. So if I want to take a drink, think a thought, upper motor nerves, just the right ones, lower motor nerves, just the right ones. Action. And here, I just think this is a great picture. Here you can see the lateral area, here and here, that should be dark as this, but it's not. It's pale because it's lacking motor nerves. So this is stained for motor nerves. If there are no motor nerves in these areas, it's pale. And here, this is the anterior horn that I showed you in the last cartoon. And these big dots, like here, there's another one. Those are the cell bodies of the lower motor nerves that would then go out to the muscles. I just think it's a great picture. So amyotrophic lateral sclerosis was named by a very famous French physician out of the Salpêtrière in Paris, it was Jean-Martin Charcot, and he gave a series of lectures to medical students between the years of 1868 to 1872. And he simply described what he saw. And I'm going to show you that in the next slide or two, what the words mean. But first, let's just talk for a second about the different motor neuron diseases. We're really going to focus on ALS, and no one in the room today said that they had PLS or PMA. In ALS, both the upper and the lower motor neurons are damaged, and they get hit, they degenerate, they die off one at a time. But with progressive muscular atrophy, it's only the lower motor nerves that are affected. So signs and symptoms that are associated with upper motor neuron damage will not be seen in the people with PMA. And likewise, primary lateral sclerosis is just the upper motor neurons. They won't have the lower motor neuron signs and symptoms. So why does it matter that we differentiate these things? Well, it matters a lot because, mostly to the patient, it matters a lot because of the different kinds of progression with this disease. So progression means getting worse over time. Is it slow? Is it fast? Does it go down in a steady manner? Those kinds of things. So ALS, we'll talk about progression in just a few minutes. In PMA, it may progress to ALS over time or not, and they may have the same progression as ALS, or it may be a tad slower. So it varies a little bit. But with PLS, it's very different. If you have only upper motor neuron involvement, and it's been just upper motor neurons for greater than 3 to 5 years, it's considered to be true primary lateral sclerosis. It's not converted to ALS. And people with PLS will live for decades usually. Mm-hmm. They'll have some mobility problems, they'll have some issues, certainly. But the progression is much, much slower. So who gets ALS anyway? For the most part, it is a disease of people in their 50s or 60s, getting just about ready to retire. This is what we've seen over and over again. But 55, 60 is the top of the bell curve. So if we look at the full adult range, it's a bell curve with the teenagers being on the low end, and then up at the top are the people with 55, 60, and then down into the 90s. You certainly can get ALS into the 90s, but it's very unusual. For some reason that we don't understand, for every 10 women who get this disease, 16 men will get it. And for the most part, the women who get it are postmenopausal. So it makes us think, is there something in the female hormones that protects women? Now, certainly I've seen plenty of young women get ALS, but it's less usual. Incidence is new cases per year, and this incidence and prevalence will vary from article to article depending on the sample, the patients that were sampled for that particular article. But on average, about 2 to 4 people get ALS in 100,000 people. So if you've got a city of 100,000 people, about 2 to 4 new cases per year. And looking at the length of life that people have with ALS, you can look at the prevalence, about 6 to 10 per 100,000. On average, these are rough numbers.
And where does ALS weakness start? For about 25% of people, it starts in the bulbar area, usually starting with speech, but this area also affects swallowing. The speech weakness starts with either slurred speech or tight, spastic speech. Swallowing difficulties usually appear later than speech problems. This is called the bulbar area because the lower motor nerves to those muscles of speech and swallowing come from an area between the brain and the spinal cord that used to be called the bulb. Today it's known as the brainstem and is a very complicated area. About a third of people will start with weakness in one arm or the other, and this is from the cervical spinal region. Another third start with leg weakness, and this is from the lumbar spinal region. That leaves about 7% of people who will start with weakness from the thoracic spinal region, and these people will start with weakness in the big muscles of the back and abdominal region, including the respiratory muscles.
So I mentioned about Jean-Martin Charcot. I love history, so I love this kind of stuff. How did he name this? So what he saw in terms of lower motor neuron loss, he saw muscle, myo, that was without nourishing factors, trophic factors. So amyotrophic. Anything in the body can become atrophic, can wither. What we see is a withering when something has atrophied. So amyotrophic is just withering of what? Muscle. So that's a lower motor neuron component. The upper motor neuron component, we've already talked about how these nerves run down the lateral sides of the spine, and they become, when you look on autopsy, you saw that nice slide I had, that nice picture. That's the real deal. That was a slice from someone who had died of ALS. It's a very old and famous slide, so that was a long, long time ago. The upper motor neurons, when they degenerate and die, they leave a little debris. So they die off, and there's a hardened, scarred area that's left behind. So there's sclerosis, hardened area, and anything in the body can become sclerosed. You can have hardening of the arteries, arterial sclerosis, etc. So there's sclerosis in the lateral columns of the spinal cord. Amyotrophic lateral sclerosis, demystified. So let's talk about some of these signs and symptoms of upper and lower motor neuron disease. And remember, people with PLS will only have upper motor neuron. People with progressive muscular atrophy will only have lower motor neuron signs and symptoms. So to have ALS, I've highlighted three things. I've highlighted three things that you must have in order to have ALS. The other things are things that may or may not be involved in any particular person. So these three things are, in upper motor neurons, brisk reflexes at the tendons. So again, the doctor will tap your knee and other deep tendons, and we'll see that they're really brisk. With lower motor neuron involvement, you must have weakness that usually starts in an asymmetric fashion, and there's atrophy. So not all weakness comes with atrophy. So upper motor neurons. Brisk reflexes, what you can, and then we go to a different kind of reflex. You can see that people who laugh, it's contagious. People who cry, somebody cries, I always tear up and I want to cry with them, just same as you want to laugh with someone. And yawning, and often when I talk about this, I'll start to yawn. It's just contagious. So you can think of these things kind of like reflexes. There is something in the upper motor neurons that when you laugh or cry, you have developed a feedback mechanism such that you have control over that. And if you don't, it's called pseudobulbar affect, PBA. So about 30% of people with ALS will have pseudobulbar affect. That's also seen in other disorders that have upper motor nerve damage. So brain injury, multiple sclerosis, stroke, they can have PBA as well. It's an exaggerated show. Feel the same on the inside, but you exaggerate the show on the outside. It's like Christmas time with the Hallmark commercial. A big tough guy, but it's a commercial that has a boy and a dog in it, and all of a sudden you're blubbering looking at this commercial. It's like, where did that come from? I must be crazy. No, you're not crazy. It's the feedback mechanism to quiet that down is gone. So there's good medication for pseudobulbar affect. Sometimes if people only have the laughing part of that, then they say, oh, my family and I kind of like that. You know, I giggle a little bit more. That's okay. And it can be to a lesser or greater degree. There's good medicine that can quiet that down quite a bit. You're not crazy, it's a wiring problem. Spasticity. So muscles that are tight, and again, you're losing a feedback mechanism. The muscle is activated, like wanting to take a drink of water. But then instead of relaxing, it stays tight. So you can see spasticity in a number of diseases where upper motor neurons are involved. Again, multiple sclerosis, traumatic brain injury, other things like that. The kind of stiffness that you get in a car or a plane, and you get out and you walk around a bit and you walk it off in 4 or 5 steps. This just doesn't go away. There's some reasonable medicine for that as well. And spasticity, you can think of a spastic bladder. So I love that commercial from a few years ago. Gotta go, gotta go, gotta go right now. There's a little jingle in the background. I can't even remember what that drug was, but I went to the bathroom every time that thing came on. So urinary urgency. Now it's not incontinence. You don't lose the knowledge that you have to go. You know when you went. So incontinence is you don't know that you have to go and you go, and then you have an accident. It is simply that you lose the early warning signal, and you got to go when you get the warning signal. It's like right now. And, if you're in a wheelchair, that could be tough. Now, there's excellent medicine for that, and urinary urgency is a problem that's pretty ubiquitous among people of a certain age, women who have had children, people with upper motor neuron involvement. About 30% of people with ALS will have some urinary urgency, and others will never have it. So that's all upper motor neuron. Let's go back to lower motor neuron. Along with the asymmetric weakness and atrophy, we can see muscle cramps. Very, very common to have Charlie horse type muscle cramps. There's good medicine out for that now as well. There have been a couple of studies in the last few years saying that mixilotine is quite beneficial for Charlie horse type cramps. So if you have problems with Charlie horse type cramps, you can talk to your doctor about that. If you just have them on occasion, maybe you don't need a pill. So there are ways to control cramps by staying warm, nice hot bath or shower, massage, some lovely things like that. Also, we used to use quinine pills. Quinine is on the market for malaria. It's an anti-malaria drug. But we used it like candy for muscle cramps. It worked quite well for ALS. But in some people, not ALS people, but in some people who were taking quinine for muscle cramps, they had developed a heart condition, and there were even some deaths. So the FDA put a black box warning on quinine for muscle cramps. So we cannot prescribe that anymore. But guess what's in tonic water? A little bit of quinine. So what's wrong with a gin and tonic of an evening, right?
People eat bananas for that too.
Yes, people will eat bananas for that, and that's because bananas have potassium in them, and some people will have cramps because of low potassium. But that's a different reason for having cramps than the reason for having cramps in ALS. Low calcium can cause cramps. Women who are pregnant get cramps a lot. But if you want to have that gin and tonic, go ahead. It might fix a lot more than cramps. In truth, though, you'd have to have about 2 liters of tonic water to get enough tonic water to help with the cramps. And diet tonic doesn't do it. It's only in the real stuff, so that's a lot of calories. Fasciculations, so the twitchies under the skin. So what are fasciculations? Why do they happen? Well, normal people, healthy people, I shouldn't say normal, healthy people get fasciculations all the time. I get them, everyone in this room gets them. You might notice them more when you've done some exercise. I used to be really good, and I would take a walk for a mile or so before work every morning. I don't do that anymore. But when I did, I would come back and I'd sit down and have a bowl of cereal, and my legs would just be a-twitching. It was saying that, yeah, you've been working that nerve muscle system. You've been working that a little bit. You know, athletes get fasciculations. Lots of people get fasciculations. In ALS, you get a lot of fasciculations, and it may very well be because your nerve and muscle system is working a little bit harder. It's like you're exercising all the time. So we see that, and what's happening is that a muscle fiber is just firing off by itself. Remember I mentioned that you have about 300,000 nerve muscle connections in the average size muscle. So some of those muscle fibers just might go off by themselves. If you get really nervous or anxious, you can get more fasciculations as well. And then fatigue. Why do people with ALS get fatigued? Well, I've already mentioned that your nerve muscle system is working harder just to get through the day. As one gets weaker, you may notice that it might feel like you're just going to the gym and exercising every day and exercising hard. And so that nerve muscle system is really working to a greater extent of its potential. So I've been told by our physical therapist that in the average person like me that, you know, somewhat active but somewhat sedentary as well, that I might be using about 20% of my muscle potential in a day. Well, with someone with ALS, maybe they're using 30, 40, 60% of their muscle potential in a day. And it gets to be like running a marathon every single day. You're pooped. You're pooped because you're working hard, which also means that you need more calories if you're working that hard. You go to the gym every day, you need some calories after you've gone to the gym, right? So we'll talk about nutrition as well. So prognosis. Prognosis in ALS is a topic that's very difficult to talk about, but I think that it's important to know about this topic. So everyone with ALS has a natural built-in prognosis or rate of progression. Progression is getting worse over time. So people who are fast, it's only 5%. But people who are fast, it is rocket fast. From time of symptom onset of weakness to time of passing away, it could be 6, 9, or 12 months. Just horrendous. And there are some genetic forms of ALS, a particular form of the SOD1 gene mutation, the A4V mutation, and we see this in those people. It's really, really tough. Slow is about twice as many people that are fast. That's a good thing. So that's about 10%. They're slow from the start. They stay slow throughout the whole thing. And they may be alive at 8, 10, 12 years or more. And these folks will often get on the internet and they hook up with each other, but they're slow the whole time. And then average, that leaves about 85% of the patients. We've got fast, we've got slow, now we've got average. Usually 3 to 5 years. Now, back when I started in ALS, we said 2 to 4, 3 to 5. My personal opinion for what I'm seeing right now, we know people are living longer. I think it's more like 3 to 6. We don't have data on that right now, but that's my personal opinion. People are living longer. We'll talk about why in just a little bit. So what are some of the factors that can affect this? So it used to be that if you had bulbar onset, well, where did we get that word, bulbar onset? Bulbar. Bulbar comes from that area that is between the brain and the spinal cord. When physicians were first looking inside people, they looked at that and they said, oh, that looks like a bulb. We'll call it the bulb. We'll figure out what it does later. And it's now the brain stem, and it's a very complex area, has lots of stuff going on there. But in ALS and in neuromuscular disease, we still call it the bulb. So people that start with chewing, swallowing, speaking issues, they have bulbar onset. They used to pass away more quickly. And why was that? Well, a lot of them passed away from malnutrition. It was superimposed on top of their ALS. If we knew about feeding tubes 25 years ago, then we would know to have people get better nutrition along the way. So the technology of feeding tubes, when to put them in, and how to use them, and the formula used for feeding tubes has dramatically changed the nutrition for people that have bulbar onset. Now, I will mention that only about a third of people with ALS will ever need a feeding tube, so I don't want to get people kind of concerned, oh, that's down the line for me. People who start here will probably benefit from a feeding tube to help them with their nutrition before they pass away. But people who start in arms or legs, maybe not. So bulbar onset. So we do know that people who start their ALS when they're older compared to people who are younger, they will move through the disease. Statistically, they'll move through the disease a little faster. So if you're younger than 45 when you get ALS, compared to people who are 65 or older when they get ALS, there's a statistical difference there. But I've seen plenty of young people who have gone more quickly, and plenty of older people who have gone more slowly. So there's a statistical difference, but what it means to one individual could be quite different than what the statistics hold. Generally speaking, your rate of progression will stay steady throughout. Some people, for reasons that we don't understand, will progress in a regular fashion, and then when they get quite weak, they'll kind of plateau and surprise us by living a year longer, or maybe even 2 years longer than what we might have expected looking at their previous rate of progression. So that's something that we see, can't predict who that's going to happen with.
I have a question. What's the longest that you personally know of a person?
Question is, in my personal experience, what's the longest I've seen someone living? 20 years with ALS. Very, very rare, but I've seen it. Now, Stephen Hawking is someone who has lived for a very long time. And when I was talking about length of life and progression here, we're talking about people who pass away naturally and not people who trach and vent and have artificial respiration to keep them alive longer than their natural course. Stephen Hawking allows his name to be used for ALS. He certainly has a motor neuron disease, but we're not really quite sure what kind of motor neuron disease he has. He has a variant. It's not clearly ALS, PMA, or PLS. He's got a variant, and he's been on a ventilator for many, many years. So I was talking, 20 years without a ventilator. That's a long time to live with ALS. So that's someone who went through all of the stages very, very, very slowly. So when we talk about progression, of course, that leads to, well, what happens at the end of this disease? What does it look like? And again, this is a hard thing to talk about, but I think it's really important because people imagine lots of things. And the imagination can sometimes be worse than the actuality. So even in the literature, there are words that are absolutely untrue. a sense of suffocation, a sense of drowning, choking to death. I don't see these things happen. My colleagues do not see these things happen. What we do see is that people pass away because they are exhausted. They are so very tired. And it's because their muscles have just given their all. It's a peaceful time, quiet, usually at home with family and friends of your choosing. Somewhat anticipated because you're going to a clinic and they're giving you guidance. You've got hospice involved to help you and your family emotionally and physically, to take some of those physical burdens, medications to help with any kind of ease of breathing. 9 times out of 10, people really don't have a difficult time, but if you do have difficulties with breathing near the end, morphine is a wonderful drug. It opens things up and helps you breathe better. Morphine is not given just to sedate people so that they don't know what's going on. You take the morphine that you need to help open up the breathing a little bit, and you can stay quite alert and aware if you don't take too much. And we do not worry about addiction. We do not worry about addiction.
Isn't it a fact that only the medical profession can administer the morphine?
The question is about, is it a fact that only people who are trained professionals, licensed medical people, can administer morphine? No, it's a prescription drug, certainly, but family can administer it the same way that you can administer any other pill. So it's totally available, and it is used, you start low and you dose escalate in a slow fashion to match the symptoms. If you're matching the symptoms, people stay more alert and aware of what's going on. So we don't see sudden breathing episodes. When the movie Tuesdays with Morrie was out, he had a really bad breathing episode in that movie. That was because he had asthma, and he had an asthma episode, and they gave him oxygen for his asthma episode. We do not use oxygen hardly at all in ALS. Only under certain circumstances is oxygen used. But people, for the most part, they're tired. They're a little bit more inward, maybe not wanting so many visitors, and they drift away in their sleep, either at night or in front of the TV in their lazy boy chair. If you think of all the ways that one can pass away, this at the end is something that one might say, oh, that's not so bad. Also leads us to think about advanced directives. So when you have a disease that's going to shorten your life, it kind of brings us up front. Gee, what do I want? What don't I want? About 5% of people, 3 to 5% of people, will choose actively to go on trach and vent and extend their lives past what it would be if they passed away naturally. So you got to let your family know, I want that, I don't want that. It's really important to have this conversation. Anyone over the age of 18 should be having this conversation with their family. I understand that it's very difficult. My son, who is 36, he knows what I do. I've been doing it his whole life, and I cannot get him to have this conversation. Cannot do it. And I'd like to think that I'm pretty skilled at having this conversation with people. So I understand the difficulty. But everyone in this room, there's no one under 18 in this room, everyone in this room should have an advance directive. Absolutely. You never know when you're going to get hit by the truck or whatever and be left unable to communicate, but still there. Durable power of attorney for medical needs. You don't need an attorney for this. Everyone in this room should have one. Everyone over the age of 18 should have a durable power of attorney for medical needs. This is where you discuss your general wishes about what you want to have happen. You get hit by the truck and your left half there, what do you want to have happen? So it's a discussion that you have over time and have it a number of times, not just once. And you designate a person who will speak as if they are you. And that means that you've talked with that person a number of times, not to be redundant, but over the decades, you talk with that person. Maybe your opinions change over time. And it's legally binding. You should have your durable power of attorney for medical needs on file at your doctor's office. And if you get admitted to the hospital for any reason, bring a copy with you. They'll scan it into your medical record. That's a good thing. But EMS, some of the EMS people, emergency medical service people, some of them will not honor it. You can show it to them and they still won't honor it. So if someone is near with ALS or any other disease, cancer, bad diseases, is near the end of life, you've got to work with your hospice organization about when to call EMS and when not to call EMS. And if you're in hospice, your first call is to your hospice nurse. They've always got someone on call, and they're there for you emotionally and physically. The 5 Wishes is a wonderful packet. Yeah, 5 Wishes is great. You can pull it off the internet. We give it away freely in a clinic, and it walks you through this conversation that you're going to have with your best friend or loved one. And speaking of the designee, it's not always the spouse that's the best person to be speaking in a time of crisis. Sometimes it's the oldest child, because maybe the spouse is just really emotionally overwrought and can't handle things at that time. So 5 Wishes, just one way that you can do the durable power of attorney for medical needs. And then there's the POST. The POST is a medical order. It's initiated by the physician. There's a form. It's universally followed, but it's only for people who are critically ill. So not everyone has a POST. You don't get a POST until you think that you might need it at some point. So a POST is a good thing. Say you're entering hospice, the POST is a good thing to do.